Dr. Ansu? Dr. Ansu is here? Yeah. Please come for your presentation. Yes, sir. Yes, sir. Dr. Vansika Khanna? Dr. Ansika? Yeah, please start.
Good morning, sir. Everyone here. Good morning. My topic is on risk factors and outcome of post-traumatic endophthalmitis in open globe injury in a tertiary care hospital. I am Anshu Jameer. No financial interest in this. Post-traumatic endophthalmitis is a severe complication of penetrating ocular trauma. It occurs in 4 to 16% of open globe injury and represents 25 to 30% of all cases of endophthalmitis. Ocular trauma, particularly open globe injury, is one of the major causes of acquired visual loss in all age groups. Poor visual outcomes can be determined by mechanism of injury, virulence of microorganisms, diagnosis and initiation of treatment, association of intraocular foreign body or lens rupture, and large wound size. Early wound closure with intravitreal antibiotic treatment may improve visual outcome. To evaluate the incidence, risk factors, and outcome of traumatic endophthalmitis after open globe injury in a tertiary care hospital was the aim of the study. This was a retrospective study done in Rio Rims, Ranchi between 21 to May 23, and this study was conducted in accordance with the tenets of the Declaration of Helsinki. Patient data, injury details, clinical presentations, and visual outcomes were collected. Details of globe injury, including laterality, initial visual acuity, anterior and posterior segment abnormalities, and imaging investigation B scan were assessed. Presence of endophthalmitis was determined by using clinical symptoms and signs: eye ache, redness, deteriorating visual acuity, purulent discharge, chemosis, edema, hypopyon and fibrin in AC, anterior chamber, and vitreous opacification. Written informed consent was taken from all the patients. The patient presented with endophthalmitis or at high risk of infection, intraocular foreign body, or delayed presentation were treated with intravitreal vancomycin 1 mg per 0.1 ml and ceftazidime 2.25 mg per 0.1 ml. Patients who had fungal infections, intravitreal amphotericin 5 microgram per 0.1 ml were given. Use of intensive topical antibiotics, steroids, and oral systemic antibiotics depended on the severity of infection and associated ocular injuries. Surgical management, including pars plana vitrectomy, were reviewed. Microbiological invest results for both aqueous and vitreous sampling and culture were collected. All the data were noted on MS Excel sheet and analyzed. 17 patients with mean age 38 plus minus 2.5 years were included. 12 patients had signs at the initial presentation. All 17 patients were given single dose of intravitreal vancomycin 1 mg per 0.1 ml and ceftazidime 2.25 mg per 0.1 ml. In 7 eyes, PP was done and intraocular foreign body were removed in 2 eyes. The visual outcome was improved in 8 patients, unchanged in 13, it changes automatically, sir. And worse in 6 patients. 53.3% had delayed treatment with more than 24 hours after open globe injury, and 37.5% out of these 9 patients had a poor visual outcome. These are the clinical findings I came across. Conjunctival hyperemia, corneal edema 11 cases, creative precipitate hypopyon, fibrinous membrane, vitreous debris in 10 cases, and absent in 7 intraocular foreign body, 2 and some cataractus changes were seen in 3 patients. Visual outcomes of post-traumatic endophthalmitis cases. These are the outcomes: Conte figure, hand movement, PL and non. These are the pics. So these are the B scan showing the echoes in the vitreous debris. The discussion: the risk of post-traumatic endophthalmitis is associated with anterior wound location, presence of intraocular foreign body, and delay in primary wound closure. It is often associated with poor visual outcomes compared to other types of endophthalmitis. The reported incidence of endophthalmitis following open globe injury ranges from 3.1% to 11.9% in the absence of intraocular foreign body. Incidence of cases with intraocular foreign body ranges from 3.8 to 48.1%. with higher infection rate reported in eyes having retained intraocular foreign body contaminated with organic matter. Conclusion is early repair with intravitreal antibiotics, treatment and PPV with contaminated intraocular foreign body removal may salvage visual outcomes, and patients with delay in primary repair, ruptured capsule, intraocular foreign body, infected wound with organic matter had a high frequency of infection. These are my references. Thank you, sir.
Thank you. One question: how do you find what is difference between your study and the study done previously on the post-op endophthalmitis cases?
Excuse me, sir, which study?
There are a lot of studies done on the similar type of things, means
Yes.
post-traumatic endophthalmitis. So do you find any difference between your study and another one, or in the literature which is published already?
There is not much difference, sir. There is nothing I can say, but it's almost somewhat.
Sir, just what you would like to propose from your study, means you have done this study, then there's some objective or something you would like to suggest?
We
that
noted in our study that if it is the early surgical repair is done within as soon as the patient comes up within 24 hours, we are getting the less cases of traumatic endophthalmitis. Sir. This
Okay,
is the,
means
and
okay. Thank you.
early
Ma'am.
repair. Thank you.
Next speaker is Dr. Vansika Khanna. She is absent. Okay. Next is Professor Mehul Shah.
Good morning to all. In continuation of the previous presentation, my paper is a comparative study of clinical
Start
features
timer.
visual outcome of endophthalmitis in case of traumatic and non-traumatic etiologies. The visual outcome following open globe injury is very poor because of numerous factors and numerous numerous variables. But endophthalmitis is one of the most devastating complications. The reported rate of endophthalmitis following open globe injury is 0.9 to 17%. In order to identify the factors affecting the prognosis of traumatic versus post-operative endophthalmitis, we retrospectively reviewed the cause of exogenous endophthalmitis. Clinically, if we see, these are the picture, and the pictures are definitely different. They are not the same because primary injury is evidence of primary injury is visible. After ethical clearance, we retrospectively review all details, demographic and clinical data between 2008 and 2022. At our institute, according to, we treated all patients, traumatic as well as non-traumatic, according to endophthalmitis vitrectomy study guidelines. Vitrectomy and intravitreal antibiotics were added to the treatment according to the presenting vision. If vision is more than HM, then the intravitreal injections were given, and if it is less than HM, then directly surgery was given. We had given intravitreal injections which are standard according to the EVS. All data exported from EMR and analyzed with SPSS 25. We found our cohort consisted of 114 eyes, and 46 were post-traumatic and 56 were following surgery. The cohort consisted of 56% male and 44% female, and mean age was 45. The overall outcome is 26, means 22.8 patients achieved more than 660 vision, and 11% approximately achieved more than 624 vision. While investigating the visual outcome, we found the significant difference between pre and post treatment with the p-value 0, and when we compared it with the traumatic and non-traumatic etiology, we did not find any significant difference. While comparing the adult and pediatric cases, we found that adults are doing better than children. 35% cases are treated only with the medical treatment, and surgical treatment has better outcome with p-value 0.001. 10.2% remained no PL, and mean number of injections were 1.38 and mean number of surgeries were 1.11. Destructive procedures were done in 2 cases. So these are the demographic data, and wooden stick and wooden thorn was the most common cause of injury. And here are the comparative study of pre and post of vision, and the vision statement already is done. So when we studied all these variables, we found that presenting vision, corneal sign, particularly corneal infiltration, type of injury in open globe injury, either globe rupture or penetrating, type of intervention, surgical or medical, age group, pediatric or adult, or posterior segment finding has a significant impact on visual outcome. This is the table where we have compared all the data from post-operative and post-traumatic cases, and we found that no significant difference amongst any variable here. So my conclusion is descriptive analysis and cross-tabulation identified the presenting vision, corneal condition, vitreous opicities, and pediatric age group at high risk of developing endophthalmitis and poor outcome. The type of intervention, subconjunctival and intravitreal antibiotic injection at the time of globe closure was associated with decreased risk of developing endophthalmitis. Comparative study of visual outcome among the traumatic and non-traumatic causes did not show any significant difference, and these are the references. Thank you.
Thank you, sir. Many questions. So next is Dr. Monisa Barik. She is present. Dr. Shobhana Rath, next presenter.
Good morning. Today my topic of presentation is blunt ocular trauma in pseudophakic patients, the prognostic factors. There is no financial disclosure. Traumatic ocular injuries are a major cause of preventable monocular blindness and visual impairment in the world, as elderly patients are prone to falling, and rupture of cataract surgical wounds and its consequences account for around 48% of ocular injuries in this age group. Trivial trauma in pseudophakic eyes needs special care as it can result in loss of vision. So the aim of my study is to study the prognostic factors for the visual outcome in blunt ocular trauma in patients with pseudophakia. We conducted a prospective type of study including 100 pseudophakic eyes who had a history of blunt ocular trauma between the age group of 50 years to 70 years between September 2022 to May 2023. Follow-up was done on day 1, day 3, day 7 and 1 month. A proper history was taken. The time of presentation after trauma was noted. The baseline visual acuity, the type of injury, ocular findings noted, and the ocular trauma score was calculated. Post-operatively, the vision was recorded on day 1, day 3, 1 week and 1 month. The patients who were between the age of 50 to 70 years who had a history of blunt ocular trauma and had undergone MICS, phaco and PCIOL implantation were included in the study, and the patients less than 50 years of age and more than 70 years who had pseudophakia and history of blunt ocular trauma were excluded from the study, along with other patients who had history of previous ocular surgery other than cataract and phakic eyes, and patients who did not consent to participate in the study were excluded. When we took a detailed history, we found out that most of the cases had multiple regions of blunt ocular trauma, and finger trauma was the most common cause, and the least common cause was found out to be being injured by cow's horn or being injured by metal pieces. When we noticed the time of presentation, we saw that most of the patients, that is 50% of the patients, presented to us within 48 hours to 7 days of blunt ocular trauma, whereas 40% presented within 48 hours of blunt ocular trauma, and the rest 10% presented to us within 7 days to 1 month of blunt ocular trauma. When we recorded the baseline visual acuity using a Snell's visual acuity chart, we noted that 45% of the cases had the visual acuity between CFCR to 6/24, whereas 22% had it between 6/18 and 6/9, and 33% had it between hand movement plus to perception of light positive. Fundoscopy, B-scan and gonioscopy was done as on needed. When we did a slit lamp examination, we found out that 10% of eyes had only subconjunctival hemorrhage, whereas rest of the eyes had some or other form of corneal involvement, and 22% of eyes had subconjunctival hemorrhage with grade 3 hyphema and PCL extrusion with vitreous loss, along with periorbital edema and ecchymosis as seen in most of the cases. Here in this image, we can see that in the first image, as indicated by the red arrow, the posterior PCIOL has been displaced, and in the second image, we can see that the iris is prolapsed to the side port that was done during the surgery, and this image demonstrates the subconjunctival hemorrhage. When we did a fundus examination, we found out that 20 cases had vitreous hemorrhage, 12 cases had macular edema present, and 11 cases could not be visualized due to excessive periorbital edema and total hyphema. When we calculated the ocular trauma score, we found out that 27 cases had 90 and 10 cases had 47. We managed all the cases after doing all the ancillary tests which were performed, and after explaining the guided visual prognosis to the patients who needed that with proper documentation, and the patients who had vitreous loss were managed with pars plana vitrectomy and SFIOL was given. We did a follow-up and we found out that on the day 1 of follow-up and day 3 of follow-up, and after 1 month there was a significant difference. After 1 month we found out that in 10 cases only subconjunctival hemorrhage was present, 5 cases periorbital edema was still present even after 1 month, and 2 cases ecchymosis was still present even after 1 month. Corneal abrasion was not seen in any of the cases. The best corrected visual acuity improved to 6/6 with appropriate refractive correction in 22 cases, whereas in 1 case the visual acuity did not improve, it remained at 6/60. The best corrected visual acuity was about 6/6 on the day 1 and day 3 of follow-up only in 10 cases, but it improved to about 6/6 and 6/9 in around 43 cases. And in the follow-up period, we found out that 5 cases were lost to follow-up at 1 week and 8 cases were lost to follow-up after 1 month. When we interpreted the data, and we found out that there was a significant male predominance, and right eye was the most dominant eye which sustained the blunt ocular trauma, and only 20% cases the left eye was involved. When we summarized all the ocular findings, we found out that hyphema was the most common presentation, which was there in 75 eyes, and iris prolapse was the second most common, which was seen in 54 eyes. Vitreous hemorrhage, only 20 eyes had vitreous hemorrhage, and surprisingly none of my cases had retinal detachment. The most common zone of injury which was involved, which was seen in most of the cases, was the zone 2. When we analyzed the prognostic factors, we found out that the patients who had an initial visual acuity at the time of presentation greater than or equal to 20/200 and had an early presentation to us like within 48 hours or within 48 hours to 1 week, their odds ratio was calculated to be 1.39 and 0.09 consecutively, and the p-value was found out to be 0.593 for the visual acuity, and p-value was found out to be 0.0028 for the time of presentation. So these were the two important prognostic indicators for the visual outcome after the proper management of injury in pseudophakic eye. When we saw that the type of injury, the non-penetrating and penetrating injuries, we found out that the crude odds ratio was 0.01 and the p-value was found out to be 0.0001, and which was also found out to be...
Shobna, kindly conclude. Your time is finished.
Thank you, sir.
Why you have done it in a cases of pseudophakic patient? Is there any specific reason for selecting these type of patients?
Sir, because when we, most of the cases which we see in our setup are patients from rural setup. Those people are not much aware. So whenever we do cataract surgery on them, even if they come for follow-up, they don't present to us on day 1, or when we advise them to come to us in 1 week also, they do not come in time. They only come to us when they feel that they have some kind of problem. So most of the cases we saw that they come to us at a time when they have some kind of injury or some kind of trauma or some kind of problem, even if we explain it to them. So most of the cases I found out that there is lack of awareness among the rural people. Most of the cases we deal in our setup are people who are uneducated and unaware of the fact that even after a PCIOL is given, we should take some extra care. So
Okay.
this was the main thing which I thought I should...
Basically, your study is good, but if you have compare it with pseudophakic patient and the blunt trauma with a normal patient, which is means a normal eye having any blunt trauma, then you can better correlate with what are the factors which are responsible for the decrease in visual acuity.
Sir.
Since you said patient were lost after the trauma to you, and then come means after surgery lost from you, and then again come with the trauma. So it doesn't matter. It doesn't exclude or rule out the possibility of the diminution of vision because of the surgery. Means if there is something happened during the surgery, so this trauma can aggravate that one, or it is only solely correlated with trauma, it cannot be explained properly.
Yes.
With this. Ma'am, any question?
Yeah, and in ocular trauma score, have you put specific score for pseudophakic? So this is something different. And what about pediatric patient? Any pediatric patient came across with
Ma'am, I didn't
pseudophakic?
include any,
Only adults?
Only adults. Only
Yeah,
the
and
cases who had undergone MICS and FACO in our city, only adult. I have
only
not done
adults.
this.
Okay. Thank you.
Thank you. Next is Dr. Sonali Panda.
Good morning, everyone. Today I am here to discuss the types of corneal foreign bodies and their correlation with specific occupation. I have no financial interest. Corneal foreign bodies are the small particles which impinge upon the cornea and are the most common ophthalmological emergency in our OPDs. Usually the patient presents with red eyes, foreign body sensation, irritation, tearing, pain and blurred vision. These cases need prompt assessment, appropriate management, that is removal of the foreign body, and necessary preventive measures also to prevent complications like corneal opacities, rust rings and secondary bacterial infections. The study was aimed to determine the incidence and etiology of corneal foreign bodies, the demographic pattern of the injuries caused by the corneal foreign bodies, to identify the occupations prone to it, and about the to know about the preventive measures to be taken considering the health and socio-economic status of the patients. This is an observational cross-sectional study which included 96 patients with diagnosed case of corneal foreign bodies. Written informed consent was obtained from all the patients. We have included patients who participated voluntarily. We have taken the age group between 18 to 60 years, and we took the cases which are diagnosed of corneal foreign bodies. We excluded the patients which are under 18 years of age and more than 60 years. We also excluded full thickness penetrating corneal injury with corneal foreign bodies and injuries with signs of corneal infection. We collected the patients' demographic data like age, gender, education, occupation, and with the time of activity they are doing by the time of injury. We taken the history of eye, whether they have undergone any eye wash or not, what kind of medications they have used, history of previous similar injuries. And after presenting to our OPD, we have each patient underwent a careful comprehensive examination with slit lamp, and those foreign bodies were removed with the help of wet cotton bud or a 26 gauge needle under the topical anesthesia. After the removal of the foreign bodies, we have stained the cornea to rule out any small perforations or penetrating corneal injuries, and we have prescribed topical antibiotics along with tear substitutes for treatment. On our study, we found the people who are working in the industrial area are more prone for the corneal foreign body injuries, followed by construction area, then agriculture and domestic area. Coming to the types of corneal foreign bodies, it was found to be metallic in most cases, around in 52% cases, followed by dust particles, then insects and wood particles. Coming to the site in the cornea, we found most of the cases in the paracentral area, around 58%, then in the central area and peripheral area. Then coming to the demographics, the corneal foreign bodies were found more in the male gender than in the female, and more in the right side eye than in the left side eye. And coming to the distribution of cases on the basis of whether we can could have prevented the injury or not, we found around 70% of cases these kind of injuries could have been prevented with the use of protective eyewear. These are some of the corneal foreign bodies we have treated in our department, in our OPDs. Like these are the examples of for metallic foreign bodies, dust particles, insect wing, and this is a case of the last one is a case of multiple corneal foreign body. One is the upper part and another is the lower part. Then coming to the discussion part, corneal foreign bodies are the most common ocular injuries that patient presented to our OPDs. The main cause of patient presenting to our OPD is like the discomfort, grittiness and pain they are suffering from. These are mostly superficial, so we can remove them with the help of topical and wet cotton bud or 26 gauge needle under topical anesthesia. Care must be taken to look for whether these are deeper or there is any kind of penetrating injury, they are kind of penetrating injury present or not. Then treatment accordingly. They account for a significant amount of time taken off work to attend the hospitals and follow up regularly. Thus, ocular morbidity may result in loss of working hours in health and healthcare care costs. To conclude, early presentation, careful slit lamp evaluation, and proper and adequate management help in the identification, also removal of the corneal foreign bodies in occupational workers, preventing complications such as corneal abrasion, infection, and scarring. My take-home message is to most of the corneal foreign body injuries are preventable. Preventive measures such as identification of high-risk areas in the workplace, use of protective eyewear, awareness of public about such injuries and their complications, and their immediate referral to the nearest eye center is much needed. Thank you.
Thank you, Dr. Sonali. You presented well. But since your topic name is the type of corneal foreign bodies and their association with the occupation, so when you are presenting next to any forum, then your conclusion should be related to that. Means what you have presented in your result or discussion, that yes, in my study we find out that industrial are the iron foreign body, industrial occupation iron foreign body are the more. What precautions you have taken, that is a general thing, that is not specific, and that is not the conclusion part of your study. But anyway, you presented well.
Thank you.
Yeah, that's what title and the conclusion doesn't.
Okay, thank you. Next is Dr. Mosmi. Dr. Mosmi Anand.
Good morning everyone. I am going to present clinical profile and characteristics of ocular trauma due to physical assault in Tertiary Care Center, Jharkhand. Physical assault is a common cause of morbidity and mortality worldwide in underdeveloped and developing countries. Assault causing trauma to the eyes become a concern of legal authorities. Ocular trauma that has a medico-legal implications in terms of punishment to the offenders or compensation for the loss. Ocular trauma is one of the major causes of monoocular, non-congenital, most under-recognized cause of vision loss in the developed world. Open globe injury is a major cause of permanent visual impairment and blindness in which ruptured globe have very poor prognosis and require immediate surgical repair. Best score is a closed globe injury, no full thickness injury, in contusion by a blunt injury, lamellar lacerations by a sharp injury, in open globe injury, full thickness injury, in which rupture by a blunt object and laceration by a sharp object. These are the image showing best score. Laceration subgroups are penetrating injury in which no exit owns, intraocular foreign body retain foreign objects causing entrance owns, perforating injury where have entrance and exit injury both present. OTC score, that is ocular trauma score, to determine the severity and prognosis of ocular injury in open globe injury, zone 1 limited to cornea and limbus, zone 2 limbus to 5 mm posterior into sclera, zone 3 posterior to 5 mm from the limbus. In closed globe injury, zone 1 limited to external anterior segment, zone 2 up to pars plicator, and zone 3 all parts behind posterior lens capsule. My aim of study is to determine the clinical profile and characteristics of ocular trauma due to physical assault in Tertiary Care Center, Jharkhand. My study is retrospective hospital-based observational study. Duration of study is 1 year. 148 cases of assault-related ocular trauma of all age groups are included. Ocular injury more than 1 month duration, non-assault related trauma treated elsewhere are excluded. A detailed history of the patient was recorded, including age, gender, injury detail, clinical presentation, time of injury and reporting time in an IOPD. Object and place of assault were noted. Vitals, visual acuity by Snell and Strand, and IOP by the Goldman Appellation Tonometer are noted. Slit lamp microscopy, direct indirect ophthalmoscopy, and report of imaging, X-ray orbit, CT scan, B scan were also noted were advised. My result is out of 148 cases in which 119 are male, rest are females. Most common age group vulnerable 16 to 30 years. Violence done by mainly known, in which family members are common rather than friends, neighbors, in which spouse are common rather than parents and others. Closed globe injury more common than open injury. Subconjunctival hemorrhage, hyphema are more common, whereas traumatic cataract is less common. Types of weapon are most commonly used only blunt object. These are the images which I collected during my study. Visual status of injured eye is mostly are normals. Post-treatment 84 people. Police information sent in 69 patients. Assault more common from home. I conclude in assault injury 54 patients have open globe injury, in which 45 patients with visual acuity less than 660, most of them by known. 80% young adult males are more prone to assault related ocular injury. Blindness is a serious public health problem as it affects person's quality of life. Pediatric eye injury have a special concern because it is prone to amblyopia. This requires a careful history and thorough examination to ascertain the actual and realistic estimation of injury. These patients may feign injuries to deliberately mislead the doctor to make a wrong diagnosis for compensation purposes. Study emphasize on urgent needs of public awareness and education program for improved outcome of ocular injury and to tackle the economy and social issues resulting in violence. The helpline may also be able to organize a support worker from the Victims Assistance Program who can organize counseling, help you communicate with police, report a physical assault, and counseling in 24-hour crisis support service. These are my references. Thank you.
So what you conclude from your study?
Yes, sir. Males are more common than females, and violence mainly done by known members, in which family members are more common.
Okay. So ideally it's more common in females, most of the previous study, but one thing more, what precautions you have taken before to register these type of physical assault or other thing in your OPD cases or the ward? Do you need write something, whatever their FIR number is there, or whatever the medical legal cases, how you prevent documents, or how will you write anything?
So by PIR numbers and inform to police earlier than any
Yes,
treatment.
for the house, most important is always write where the first MLC has been done,
Yes, sir.
and then what is the FIR number and what are the things, because these are the cases in which you do study, that is different thing, but it's a lifelong liability on the treating surgeon.
Yes, sir.
So whatever the presenting vision is there, when the patient is presented to you time, it's a huge list. But at least you can do 4-5 things which is very much important before starting treatment, or at least document on your file in your own words along with your full name and everything. Thank you.
Thank you, sir.
Next.
You didn't find any child in your study? You didn't find any child in your study? But so there is a separate score, it is POTS, it's a pediatric ocular trauma score which you need to apply for that. And nowadays toddler ocular trauma score has come. So you cannot apply this adult ocular trauma score when you are putting this clinical profile.
Next is Dr. Jessica. After that is Dr. Iram. Dr. Iram is here. Dr. Iram. Dr. Rashri Pandey. These two are absent. Dr. Arun Kumar. Yeah, please start.
Good morning, respected judges and everyone present in the room. My name is Dr. Jessica Basumatari, and I'll be presenting a talk on USG-based study of ocular trauma in a tertiary care center in Northeast India. Introduction. The WHO has estimated that blindness resulting from ocular trauma affects approximately 1.6 million people worldwide annually. The incidence of blindness associated with facial injuries is very high, it's around 10.8%, and the examination of globe is difficult after trauma. The presence of periorbital soft tissue swelling and other injuries pose difficulties during the examination, along with factors like poor patient cooperation. In such conditions, B-scan ultrasonography is an imaging technique which can be utilized. It is non-invasive, user-friendly, reliable, and reproducible. My study is a hospital-based retrospective study. EMR of all patients who presented to the emergency clinic with ocular trauma and underwent ultrasonographic examination of the eye from January 2020 to December 2020 were reviewed. Details such as the date, time of injury, time of presentation, eye involvement, mode of injury, type of injury, and B-scan findings were noted down, along with demographic details like age and sex of the patient. In fresh globe injuries, the globe was first repaired, following which the B-scan was done. So the sample size was 275 eyes of 269 patients. Inclusion criteria were ocular trauma, in which the posterior segment evaluation with IDO was not possible, because of which B-scan had to be done. And second, ocular trauma with clear media in suspected IOFB cases. Exclusion criteria was infective keratitis secondary to trauma. The results were, most of the patients, the age group, mean age group was between, the range of age was between 9 months and 82 years, and the mean age was 25 years. Children were found to be more susceptible to ocular trauma, around 36.8% were involved. Sex distribution, males is to female ratio was 3.9:1, and in my study, open globe injury was found to be more common than closed globe injury. Time of presentation, most of the patients presented between 3 to 7 days. Within 1 hour, only 2 patients out of the total 279 patients had presented. The most common source of injury was a non-metallic object, which accounted for injury in 48.32%. Metallic objects accounted for 23.79%. Other causes were firecracker and physical assault, RTA, blast injury, and chemical spillage. Visual acuity at the time of presentation was recorded in 82.54% of eyes. A visual acuity of counting finger at 1 meter to light perception was recorded in most cases, that is 70.04%. In ultrasonography finding, most common finding was normal ultrasonographic study, followed by retinal detachment, followed by lens injury, vitreous hemorrhage, and others were ONH, avulsion, IOFB, endophthalmitis, panophthalmitis, phthisis bulbi, and hematoma in orbit. So these are some of the pictures that I collected. The first picture is a picture of retinal detachment. Second, a vitreous hemorrhage with inferior layering. Third is a picture of a posteriorly dislocated lens. This is a picture of intraocular foreign body with a very high spike and posterior shadowing. Then choroidal detachment with dome-shaped lesion. Endophthalmitis, panophthalmitis with T sign, optic nerve avulsion, and phthisis bulbi. So discussion, when compared with other studies, we found similar findings in other studies as well. In our study, most of the patients had normal findings on B scan, which was seen in other study like this one, which was conducted in a hospital in India. The male is to female ratio in our study was higher than other studies. It was 3.9:1, whereas other studies like I have listed below, the sex ratio ranged between 2.7 to 2.9:1. Children were found to be more susceptible to ocular trauma, followed by middle-aged adults, which was comparable to other studies. The most common source of injury was a non-metallic object, which account for injury in most of the patients, 48.32%. Which was also found to be similar to other studies. And in our study, open globe injuries was more common, whereas other studies had closed globe injuries. So the conclusion, to summarize, ultrasonography database can be utilized to determine the burden of ocular trauma in society. And the WHO estimates that blindness from ocular trauma affects approximately 1.6 million people annually, and B-scan is an important imaging technique for examination of globe after trauma, which can be quite challenging. Thank you. These are my references.
Thank you, Dr. Jessica.
Yes.
What are the limitations of your study?
Sorry, sir?
What are the limitations of your study?
So the limitation is that it is a retrospective study and it is a descriptive study. So I could not make any correlation between, say, the time of presentation or the visual acuity and the final visual outcome. That was not done. However, I have managed to gather other information like male is to female ratio, then the findings on B scan and such. Thank you so much.
Thank you. I'm just reconfirming again. Dr. Iram, Dr. Rasri Pandey. Iram, she is not there. Dr. Rasri Pandey, Dr. Arun Kumar, Dr. Raj. Dr. Sasmita Sahu. Yeah. Her paper is one of the keynote paper because she won the best paper award in her state conference.
Good morning, everyone. My presentation is on large wooden intraorbital foreign body, a case report. There is no financial support and sponsorship, and I have no conflict of interest. Introduction. Intraorbital foreign bodies are a global phenomenon and occur with a frequency of 1 in 6 orbital injuries. However, intraorbital wooden foreign bodies are uncommon. Intraorbital wooden foreign bodies predominantly affects male population with a mean age from 18 to 25 years. These vegetative foreign bodies must be removed as it serves as a needles for orbital infection. And we report such a case of a large intact intraorbital wooden foreign body which was removed successfully and improvement seen in the ocular status of the patients. Case history. A 25-year Hindu male from Keonjhar, Odisha presented to our casualty on 15th March 2022 with a sustained wood penetrating injury in the right eye. He had a history of accidental fall from the tree on the same day. On examination, his GCS was 15 out of 15 and on ocular examination, his visual acuity was perception of light in the right eye and 6/9 in the left eye. There is restriction of extraocular movement in all direction in the right eye. On anterior segment examination of right eye, there is a mild proptosis along with congestion and chemosis. And there is a sealed corneal tear present with a corneal edema. Pupil was dilated and not reacting to light. The AC was maintained, and a large wooden foreign body located at the medial canthus, as we can see in this picture. Fundus examination was not possible in this case because of the hazy media. The CT scan of the orbit was done and air density was found in between medial wall of the orbit and globe. There was no intracranial or nasal cavity penetration, and the globe was intact too. Coming to management, the patient was hospitalized immediately. Injection tetanus toxoid, intravenous antibiotic and analgesics along with moxifloxacin eye drop were administered. After neurological consultation, the case was planned for the exploration. After giving the peribulbar block, under all aseptic condition, with the help of artery forceps, the wooden piece was removed intact, and the size of the foreign body was 8 into 3 centimeter. The wound area was clean, and the gap was closed by retracting the globe medially with 6-0 vicryl suture. Intravenous ceftriaxone, diclofenac, and pantoprazole, along with oral fluconazole, antibiotic with steroid eye ointment were given post-operatively. These are the images of the patient on pre-op, intra-op, and post-operatively. And there is an image of the intact intraorbital wooden foreign body. Coming to the post-op status, on day 1, the wound was healthy, no discharge, chemosis and corneal edema subsided, the pupil was dilated and not reacting, and his vision was still perception of light. On day 3, there was mild congestion present, chemosis resolved fully, and the vision was perception of light. On the day 4, the patient was discharged with oral antibiotics, steroids, and topical eye drop and ointment. Coming to discussion, the retained wooden foreign body may lead to complications like prolonged suppuration, cellulitis, abscess formation, panophthalmitis, and extraocular muscle damage. As there is no definite imaging studies, CT scan is usually performed in orbital trauma cases where foreign body penetration is suspected. After excluding the possibility of the metal foreign body, MRI can be performed. Surgical removal of the wooden foreign body requires extreme caution, and utmost care must be taken to prevent fragmentation of the wooden pieces during extractions. To conclude, 90% of the orbital injury is preventable, so prevention is better than cure. And implementing appropriate imaging modalities for diagnosis and care for surgical removal of foreign body is critical to minimize the complication and a good post-operative outcomes. These are my references. Thank you.
Thank you. What are the steps you recommend for the prevention of these injuries?
First, we need to correct the refractive error. As in my case, the patient is having 6/9 in one eye, so that is the first thing. The second is we can ask the patient to wear glasses while working to protect the eye.
Okay, thank you. Now we request all the presenters for group photograph. After that, we finish the session.